maybe to come down to looking for other, because you need to always have in the back of your mind that there may be some other cause. So you look at the baby's hands and fingers to check the correct number of digits in the baby's hands. When you see this sort of image, you want to check, is there syndactyly? So if you look at the fingers, you ask whether there's a syndactyly of the second and third, and just wait. Sometimes the baby's two hands are holding, so the babies are holding hands. It can make it look abnormal when it is actually normal, so then you shake the baby to try and get the hands to separate. And if it doesn't separate, then come back and look at the hands later. It's not, abnormality of the hands is not a feature of Turner's. So if you come across the hands that now separated, and then you come back to look at the fingers. So the position of the fingers, I need to continue to look at this, but it's just an unusual position of the fingers of the hand. So if I see that, I come back to it later on in the scan, and I also just check on the four sides. I think the baby does have 5 fingers on both sides, but it's just the position of this I need to check a little bit later. So let's go back to have a look at the baby's heart, just to see if we get a little bit more detail on the heart. So once I'm on the heart, I go to a cardiac preset, and down to the fourth chamber. Now the first thing that I notice is that the axis of the heart is deviating to the left. So if you draw a line here between the anterior chest wall, and then draw a line between the anterior septum, you see that the baby's heart is on its side, distance. You see that the interventricular septum is at 90 degrees. So this is left cardiac axis deviation. And cardiac axis deviation is one of the most strongest markers for congenital heart disease. It's stronger than increased translucency, stronger than progressive valve regurgitation. So that's a very strong marker for me to see the baby's heart is rotated to the left. I need to then know why is it rotated to the left. So if I come around then to look at the fourth chamber again, and I want to make sure there's not an AVSD. In this session of Turner's, I need to look at features of coarctation of the aorta. So with the bladder empty, I'm getting a better view now of the atrioventricular valve. Now I'm looking here to see whether there's narrowing of the aorta as it leaves the left ventricle. So I'm going to go to power Doppler. When I go to power Doppler, I can see that image where the left cardiac ventricle is smaller when compared to the right. And you can appreciate that on collar fill. So if you look at this here, it's giving you a right cardiac ventricle, here generic. I keep coming up with that, generic distance. So this here is my right cardiac ventricle here, and this is my left cardiac ventricle here. So when I see that, I want to look at the aorta and see the ascending aorta. So if I look at that, see the aorta coming out of the left ventricle. This is the point the aorta just exiting. Because here I follow the swan neck here to the aorta. And when I get up on the I want to try and get a true vesical view, and it's just in a difficult position. So seeing a baby with mosaic Turner's, small left ventricle, at 50 weeks and 6 days in the hydroxytalus, are all the features that make me suspicious of the baby having coarctation. The other feature is important to check is the renal tract, just to make sure there's no renal pelvis dilatation. So if you look at this baby's got a duplex kidney on the near side, if you come across, you can see there's 2 renal pelvises, and then check the kidney on the opposite side and there's a single renal pelvis. So this here has got 1 renal pelvis here, 1, and then this one here has got 1, and 2. So a duplex renal system is another marker that you may get. And when you look at the kidneys and you see a duplex system, you want to just check and see whether it's the renal arteries. When you're looking at the renal arteries, you put on power Doppler. You see sometimes with a duplex kidney, you may find that there are 2 renal arteries. We're bringing that down, you reduce your PRF to get the renal arteries coming off the supply of the kidney. And you bring that down to 7 centimeters a second, and then increase your output, your power output, and then you have your first vessel you see coming in here. That's not your renal, this is your suprarenal artery here. And then if you cannot see your renal artery, then you just go to slow flow and see if the slow flow will show you. So I can't see the renal artery coming in. If I cannot see the renal artery coming in and I see a duplex, remember always have in the back of your mind the possibility of there being a horseshoe kidney. It's because you will not see normal renal artery in the baby with a horseshoe kidney. But before you jump to that diagnosis, go to slow flow and then increase the power in slow flow. And in slow flow, I might just take the background. And background on. And now I'm going to look to see if I can see both of the renal arteries supplying both kidneys. And as I look at it here, I can see a renal artery on this side and a renal artery on this side. I think the renal arteries are present and normal, but there's a duplex system on one side. Also important to check down the umbilical cord, just to make sure there isn't a single umbilical artery. So we'll come down to that. And also check to make sure the both kidneys are present. So you come on to that, you'll see here, put on colour, and again you can see both arteries. When you're looking at this, again, make sure that you are seeing a urinary bladder. Stop reading for a second. If the baby mother's breathing a lot, just ask her to stop breathing. It helps with slow flow. If the slow flow is so sensitive to colour. Once you've got your image, center your image, magnify your image, and now you can appreciate that there's a difference in the umbilical artery sizes. And this is that one. So this is the umbilical artery on this side, and this is the umbilical artery on the opposite side. It's important to document this because discordance in the umbilical arteries it becomes relevant in the third trimester of pregnancy. If you have abnormal Dopplers, you may be sampling the small one. You should always sample the biggest artery and act on the result of the biggest artery, not the smallest. Coming back to the baby's hands, the hands now look normal to me, and I think the baby was just stretching his fingers, so when I look at this, I can see the fingers on both sides. I don't think there is a single accident. I can see 3 leaves there beside each other, but I do not think that they are reduced. And that's it. I think we better go back to the lectures. Are there any questions from anybody in the audience? I'll finish up by showing you that fourth ventricle, so you can see that fourth ventricle. So you come across here, and this is your cerebellum here, and then this is your more than likely to be a plate type.